We are very excited to have Dr. James Valeriano here with us today to introduce us to the STARS study. He's going to give a little bit of background information as well. Dr. James Valeriano is the chair of the Department of Neurology at Allegheny Health Network and the director of the Comprehensive Epilepsy Center at Allegheny General Hospital. He has more than 40 years of experience caring for patients with epilepsy. Dr. Valeriano is a member of the Epilepsy Association of Western and Central Pennsylvania's Board of Directors, and he's also a member of the National Epilepsy Alliance America Professional Advisory Committee. So he does a lot for the epilepsy community, and we are so thankful to have you here today to share some information with us as well. So I will, with that, turn that over to you, Dr. Valeriano. Thank you so much.
Hi. Good afternoon, everybody. So two things. Our building flooded in the basement, so we have no heat today, so I might talk fast because of that. But on the other hand, they're actually going to have to shut the power off to our building, they said, in a half hour. So I'm going to go a little faster than I may have, but I think I should be able to get the main points in a half hour. So that's my title. And I'm just going to go right to the idea of rescue medicines. So there weren't rescue medicines in epilepsy before. The concept of rescue medicines is not new in medicine. If you think about people have angina, the heart, chest pain, they take nitroglycerin. Now, naloxone, which is given for opioid overdoses, is a well-known rescue medicine. Albuterol inhalers for people that have asthma. But epilepsy was kind of late to the game to get true rescue medicines. What do you do to prevent ongoing seizures or to prevent the next seizure? As this says, emergency condition. If you look at the bottom, seizures, seizure clusters, and status epilepticus. What do you do when that happens? What are rescue medicines? So if you look at the United States, about 3,500,000 people in the United States have epilepsy. About 40% of those are not well controlled with their medicines. Of that group, about 5% of those with active epilepsy, meaning those that are not well controlled with their medications, about 170,000 people in the United States with epilepsy experience episodes of frequent seizures, or sometimes the idea of seizure clusters, seizures that group together, more than one seizure on a given day, or prolonged seizures. So there's a group among the people that have active epilepsy that's even kind of worse in that way, that tends to have seizures in groups. So there's different words for these, or different ways to categorize seizure clusters. Some of the alternative names were acute repetitive seizures, recurrent seizures, flurries of seizures, serial seizures, crescendo seizures. But the idea was, if you look on the left side, seizure clusters can be broadly defined as acute episodes of consecutive seizures that occur with short interictal periods and may be distinguishable from a patient's typical seizure pattern. It's basically, people, seizure clusters when you see them, even if it's a little bit hard to describe them or to define them. But again, the idea is these are seizures that come in groups, more than one seizure, seizures sequentially, or even just more than one seizure in a day, or the tendency to have prolonged seizures at one time. So again, if you look at the bottom of the slide, patients who experience seizure clusters represent about 15% of the uncontrolled epilepsy population, about 5% of the epilepsy population total. So the other slide said about 170,000, so about 150 to 200,000 people that would be candidates for these type of medicines in the United States. In other words, rescue medicines. So when people have seizure clusters, what are things that lead to that? What are the risk factors for experiencing seizure clusters? So they do tend to happen more with people with focal epilepsy. So epilepsy that starts in one part of the brain, sometimes now called focal onset impaired awareness epilepsy or focal onset awareness. This just means that one part of the brain becomes active electrically and the seizure starts focally in one spot rather than starting from all over. Symptomatic generalized epilepsy is a type of epilepsy that you see in people with significant brain injuries. So this is people that have things like Lennox-Gastaut syndrome. Some of you may be familiar with that. But these are people that have really very difficult to control seizures. Seizures tend to come in groups. If you look at the other things, they're just basically things that happen to people. So if you have a history of CNS infection, if you have a history of meningitis, encephalitis, again, that makes it more prone to have seizures in clusters. If you look on the right hand, so people that have a history of status epilepticus, in other words, people that have had prolonged seizures, people that have had repetitive seizures are at a risk for that to happen again. People that have failed 2 or more seizures, anti-epileptic drugs, seizure medicines. Again, the idea is that these are people with refractory seizures, seizures that are hard to control. So what should be done when you have this? So what do we do with these rescue medicines? Basically, idea of a seizure emergency action plan. So this is a survey of 259 adult patients who experience epilepsy, with epilepsy, who experience seizures in clusters. 70% of these people do not have a seizure emergency plan, so they don't at this point use rescue medicine. So the idea of rescue medicines, really, the time has come for this, because there's a lot of people, even now with the advent of these drugs being available, where that people don't use them. So if you look on the right side where it says clinicians, what do clinicians recommend in patients' responses to seizure clusters? 80% of clinicians will recommend rescue medicines. Only about 20% of people use those. 20% of people call the doctor's office. 24% visit the ER. Some people take an increased dose of medicine. They might go to an urgent care center. People that have vagal nerve stimulator, that's VNS, may use the magnet to activate the device. But again, the take home here is most patients with seizure clusters report that they don't have an emergency plan. So when something like this happens, and again, if you have seizure clusters, it tends not just to be a once and done kind of thing. They don't have a plan as to what to do to stop the next seizure. So what happens? Patients urgently need a way to treat seizure clusters to avoid serious consequences. So what happens when people have multiple seizures, untreated seizure clusters? What happens to people like that? 30% of people report bodily, and again, this is not just seizures, but seizure clusters. 30% of patients report bodily injury linked to the seizures, such as head trauma, burns, dental injuries, fractures. It depends on the seizure types. Again, the more seizures you have at one time, and again, if you have a second seizure, a third seizure, you're not protecting yourself, maybe because you haven't recovered from the first, your chance of falling down and hitting your head, fracturing your clavicle, fracturing your skull, increases. I've had people that have had this that have fallen onto stoves and got burned with that. So the repetitive seizures increase your risk of physical injury. Obviously, if you have repetitive seizures and they're not stopped, there's a good chance you're going to end up in the emergency room or get hospitalized for this. If you have recurrent seizures like this in groups of seizures, your chance to develop what's called status epilepticus. Status epilepticus means your seizures can't be stopped. They actually require basically very high doses of intravenous medication, or even have to get put on a respirator, have to get intubated, put on a respirator, and put on anesthetic agents. So status epilepticus occurs 3.5 times more in clustering patients than in patients who do not have clusters. Again, so the seizure clusters, it's an ominous thing to have these. Neurologic damage. Repetitive seizures have been associated with long-term cortical brain damage and cognitive decline. Again, seizures after a while take a toll on people. You can actually have dropout of neurons, of brain cells that get injured just from having the seizures, just from the electrical discharges in the brain, wear out basically the neurons and they drop out. So people that have repetitive seizures, that's more likely to happen to. And the mortality risk, the risk of death is about 3.5 times greater than in the general population with epilepsy. Again, this is people with seizure clusters. And the general epilepsy population already has a higher risk of death than the general population because of seizures. So again, there's a lot of bad things can happen if you have repetitive seizures. So the importance of early treatment. The other thing, rescue medications, as I pointed out before, were underused. So about 80% of people do not take these. 31% of patients, this is in a survey of the greater than 200 patients that had seizure clusters, 31% of those used the emergency room in the 12 months preceding the survey for their seizure clusters. In other words, they weren't treated at home. They went to the ER. So a third of these people went to the ER. If you look at the middle slide, the middle part of the slide, it takes about 56 minutes to get to the hospital, and that's with EMS being called, and then about 42 minutes to get treated. So it's almost 2 hours, and during that time, you can have more seizures, and as I mentioned before, the more seizures you have, the harder they are to control. So having a rescue medicine available is very important, and the sooner you can use it, the better. So this just historically, this will get to what we're going to talk about, the option we have now. So historically, options for seizure rescue medicines were limited. The first medicine that got approved on the left side was a rectal gel called Diastat. This was rectal Valium. And this actually did get FDA approved to treat seizure clusters. But as you can imagine, this is not a very pleasant thing to do. You have to give somebody a suppository with this rectal gel, and they've just had a seizure or they're in the midst of having other seizures. Obviously, this is something that's very difficult to do at the time, especially to get the dose in correctly. Obviously, people can't give this to themselves. And obviously, it's very hard to give this if something happened in public, even if you're going to give this to somebody else. There were oral tablets and wafers used, Klonopin wafers, some of you may be familiar with. These are rapidly dissolving wafers that got into the system, probably in 15 to 20 minutes. And the idea was, again, maybe you could stop the next seizure with this. These at least could be self-administered, but the dose is modest, and it really does not go in as a bolus of medication. It seems when you give medication at high doses quickly, that's more likely to terminate seizures than if you're giving something in like this, more of a dissolvable tablet, or certainly more than if you're giving a pill. Also, at Children's Hospital, they made atomized benzodiazepines, so this was not FDA approved. The pharmacists at Children's could actually make up a solution like this that they put in a syringe with a bulb in it. People could take it home and they could spray it in their nose. This was basically a benzodiazepine at this point, a drug called midazolam that was given, which is in the family of Valium and things. But this was sort of unreliable and kind of a jerry-made kind of thing. So again, it was better than nothing, but certainly was not optimal. This is just to show you, and this is where I want to get to what we're going to talk about, but just to give you an idea. So the nasal sprays, if you look over here on the left, one of the nasal sprays has diazepam in it. That's NS nasal spray. So the peak, to get to the peak of absorption of this is about 1.5 hours. Now, the drug actually can become more effective. It doesn't have to get to the peak concentration to work, but it probably still takes 20 minutes or so, somewhere around there, 15 minutes. If you look at the nasal spray with midazolam, that's one of the other commercially available nasal sprays. This gets in a little quicker, probably in about 30 minutes. But still, again, the idea is you're trying to prevent the next seizure, or can you prevent ongoing seizures? So with the two nasal sprays that are available, the one with midazolam and the one with diazepam, it does take a little while for these to get on board. These are effective medicines, but again, they're more to prevent the next seizure from coming on than they are to really try to prevent an ongoing seizure, or the seizure you're having right now. So what we had before is I'm just going to go back quick. So the idea was we had rectal Valium. We had a way to give a medication rectally. That was the delivery system. We had oral wafers, which were okay, but didn't get in that quickly. And then we had the atomized sprays that were made by pharmacists themselves. And then we had nasal sprays. So this was the nasal sprays was obviously an upgrade from what we had before with the with rectal Valium, with the Diastat. But again, it was a little bit of a slow onset with this. So we now have developed rescue medicines. The delivery systems first were, as I said, wafers, or the FDA approved was a rectal gel. Now the improved part was with the nasal sprays. Now, is there a way we can improve that? Is there a way we can give this even quicker to get this into someone's system more quickly? And that's where this drug study is, the Staccato alprazolam. Alprazolam is, in the generic name of this, and familiar would be Xanax. This is another type of benzodiazepine. So the available nasal sprays are midazolam and diazepam. This is alprazolam. They're all in the same family. They're all benzodiazepines. So these are things that are used to treat acute seizures. So this study that we're involved in is a double-blind, randomized, placebo-controlled, multi-center, outpatient, parallel group study. I'm just reading this, obviously, to assess the efficacy and safety of Staccato alprazolam in study participants. You have to be 12 years of age or older with stereotypical prolonged seizures. So what this means is, what happens in the study is it's a double-blind study, so it is a placebo-controlled study. In the study, though, you only need to be treated one time, and I'll get to who would be a candidate for the study. You use the medication one time. You may get a placebo with the medication. There's an open label part after that. So if the medicine works, you can go in an open label study and continue to get the medicine. If the medicine didn't work and you didn't want it, and it turned out when the randomization is broken and you find out what you've gotten and the medicine didn't work, you don't have to go into an open label study if you didn't want to. If you got the placebo, if you found that it didn't work and you got the placebo, you could then enter the second part of the study, in other words, the open label study, and you would get the alprazolam. So if you would be in the study, everyone eventually will have access to this medication. Again, the one thing to be clear about, and this is true when you do studies, we don't know if this works. That's why you're doing the study. So what we're trying to find out in this study was how well did this work and how quickly does it work? Because one of the things I showed you before in the slides about the benzodiazepines and how quickly they get in, it does take some time to get in on board with the nasal sprays. The nasal sprays really take, as I said, probably 30 minutes or so, 20 to 30 minutes to get on board. The idea, I'm just going to go to the next slide and see. So the idea with this is an inhale. This is a orally inhaled. So this goes through your lungs. So this medication gets on board the same way as if anything you would inhale, like an albuterol inhaler that you use for asthma. The idea is this is in your system extremely quickly. So the difference in this medication with what we're interested in and the nasal sprays is the nasal sprays or the rectal Valium are really to stop seizure number 2, seizure number 3. The idea with this medicine, because the absorption is almost instantaneous, this is a quicker absorption because the delivery system's different. The idea is, can you stop seizures now that are happening now? Not, hopefully you'd also, obviously, you want to stop the next seizure, but this is also the idea. Right now we don't have a medicine for an ongoing seizure that you could get at home that would work immediately or work almost immediately. With the idea with this is because this goes through your lung, this is a much quicker absorption system. And will this work? Will this stop seizures that are occurring right now? And again, we believe that if that would happen, it would also be effective for stopping the second or third seizure. But the idea is this is a different system, it's a different way to deliver the medicine, and it's a quicker absorption. That we know this is absorbed more quickly than the nasal sprays. The question is, would it be effective? Now, so who would be? Let me just go back once. So who would be available? I mean, this is what's called the inclusion criteria. And the one problem is this is really fairly strict, and it's hard to find people exactly like this. But this is what we would be interested in, because again, the idea is we know the nasal spray medicines are effective at stopping seizures down the line. What we're trying to find out here is, can we stop an ongoing seizure? So the inclusion criteria, this can be any of these. So person that has a generalized seizure episode starting with a flurry of absence seizures or myoclonic seizures with a minimal total duration of 5 minutes. So most of you know what absence seizures is. These are just little blank out seizures, sometimes called petit mal seizures. Some of you may have what's called juvenile myoclonic epilepsy, which is not a rare condition, and they can wake up in the morning and have these series of little muscle jerks, myoclonic jerks. The thing with all these, and why this is a little bit of a difficult study with inclusion, is your seizures always have to last that long. Because if you have some seizures that last 2 minutes and some seizures that last 4 minutes, and you take the medicine, we don't know, is this just because and it stops in 2 minutes, was this because your seizures normally can stop in 2 minutes? So the idea is these seizures, when you have this flurry of absence seizures or myoclonic seizures, it has to be a minimum duration of 5 minutes all the time. So that way, if you get the medication and the seizure stops before 5 minutes, we know it's the medication and not the natural history of your seizures. That's one way you can get in the study. Second way is episodes of focal seizures with a minimum duration of 3 minutes. The most common focal seizure like this is probably what we used to call and still can call a focal motor seizure. So somebody has jerking of their right side of their face and their right arm, or their left arm, or one of their legs, or twitching of the face. You can also have these where these can be prolonged confusional spells. So what sometimes now, older term was complex partial seizures, newer term focal onset impaired awareness seizures, where people get confusional spells with these seizures. They lose awareness, and that lasts a minimum duration of 3 minutes. But again, these are focal seizures. They can be focal seizures where you maintain awareness and just have motor components, muscle components, or they can be seizures like focal seizures that they play out as confusional spells. But again, the idea is when you have these, they have to last at least 3 minutes, and all of them have to last at least 3 minutes, so that if we can terminate the seizure before 3 minutes, we know it's the medication and not just the natural history of your seizures. A third way you can have this is episodes of focal seizures or myoclonic seizures that last for 90 seconds, followed by a generalized tonic-clonic seizure that lasts at least 3 minutes. So these are sometimes called focal seizures that secondarily generalized. As I talked before, when people have myoclonic seizures, in juvenile myoclonic epilepsy, they'll often have muscle jerks that occur, and that can go on for several minutes. If it goes on long enough for 5 minutes, like I said, that could get you into the study if you were interested. But sometimes if they last less than that, they may then go on to have a grand mal seizure, a generalized tonic-clonic seizure. So if you have episodes of myoclonic seizures, myoclonic jerks that last for at least 90 seconds, but not 5 minutes, but unfortunately they go into a generalized tonic-clonic seizure, a grand mal seizure, and that usually will last 3 minutes. That would be a candidate for the study. Or there's people that have focal seizures, like focal motor seizures. Their right arm jerks for a certain period of time.
You're done, call me and I'll get you where you gotta go.
I'm sorry, I'm on the webinar, says you mean,
They haven't shut it off.
okay, all right.
When you're done,
All right.
call me and I'll get you where you need.
Okay. All right, so I'm sorry, yeah, so we're still finding out about shutting off the power. Anyway, so episodes of focal seizures so seizures that start focally, last for 90 seconds, and then generalized, that also gets you into the study. So again, one of the hard parts and what makes this a little bit difficult is that your seizures always have to be the same duration, and those are the minimum durations. So absence seizures or myoclonic seizures at least 5 minutes, focal seizures like focal motor seizures, or focal seizures where people are confused at least 3 minutes, or focal seizures or a flurry of myoclonic seizure for at least 90 seconds, followed by a grand mal seizure. When you do, to screen people to find out if they're eligible, and again, because you want to have people, unfortunately, that are having seizures. So prior to screening, the patients have to have experienced for 4 or greater that should be a 4, not FOR, that should be FOUR. 4 or greater stereotypical episodes of prolonged seizures in the past 6 months, and at least 2 in the last 3 months. In other words, one of those 3 criteria above, you've had to have 4 of those within 6 months and 2 of them within the last 3 months. Some of the exclusion criteria would be, because this is an inhaled medication, some of the exclusion criteria can be people that have significant lung disease can be excluded. People that are on opioids for some reason, even if they're legitimately on opioids, they're taking them for pain control, they're excluded from the study. But by and large, if you have these type of seizures that we're talking about, we can screen you and talk things over with you and decide if you would be a candidate or not. So you could probably just get a hold of Peggy at the Epilepsy Foundation. She can get a hold of us. So if anybody is interested in this study, let her know, she can let us know, and then we can contact you by phone and go over some of the ins and outs. And if some of this it seems a little confusing, I mean, that's understandable. It's a little bit more sort of clinical things than you may be used to. So even if you think you may be a candidate for that, we're certainly happy to talk it over with you and say, yes, indeed, what you're describing, it fits in with what we're looking for, or it doesn't, or there's some other reason why you may or may not be a candidate. So if you let them know, we can contact you. But again, the idea here and where this would be a big advance and why we think this is an important study is this is to try to stop ongoing seizures and not necessarily the second seizure or the third seizure. Again, if it stops the first seizure in its tracks, we would expect it will stop the ongoing ones. And again, we don't know that. But right now, there's nothing that gets in your system immediately, a rescue medicine like this drug would. So in that way, this is a big advance, the delivery system of the inhaled medication. And that's why we're excited about this. And we really would like to, we need a few more patients nationwide to conclude the study. And again, we don't know the results. I want to be clear about this. I'm not telling you we know this works. We don't, but that's why we're doing the study. But we need a few more patients to reach a certain critical mass where we can start to disclose the outcome. So if anyone has any questions, I think that's basically what I was going to talk about today. So if anybody has any questions about this, I'd be happy to answer them. I don't know if there's a chat on the Zoom or if anybody has anything they wanted to ask, or Peggy or Andrea, it's up if anything I can answer.
I don't see anything in the chat at the moment. As you said, if anybody has any questions or thinks that they're interested, they can certainly get in touch with me or with Andrea, and we can get them connected with your office.
Yeah, like I said, we'd be happy. And if it's not clear exactly what because this is a lot of information pretty quickly. And if
Right.
even you're not sure, you think, well, geez, that would be interesting to me. I'm not 100% sure I would meet inclusion criteria. Just have them let you know, Peggy. We're happy to talk to them and discuss whether or not they'd be candidates. And I said, this is really, I mean, in some ways, this may be a revolutionary product if it turns out it does work because how rapidly it gets in people's system.
Right. I know, Dr. Valeriano, sometimes patients are sometimes hesitant about participating in some of these studies, sometimes because of the number of visits that they have to make to the doctor's offices and that sort of thing. Can you give people any sense of how often how many visits they have to make to your office to participate?
Overall, Peggy, and I apologize, I don't remember. I think it's about 6 visits. There's
Okay.
there's a couple other visits along the way. There's a visit after they take the medicine. There's a follow-up safety visit. So I think it's somewhere around 6 visits.
Okay. And there is one question in the chat that says, my daughter has LGS. Do you have other patients participating with this condition?
Yeah, I mean, theoretically, that's, if you look back, people with Lennox-Gastaut often have flurries of seizures. That's not uncommon at all. One of the things I should have mentioned, because you also need to have one of the inclusion criteria is you need to have a caretaker or somebody with you that can time how quickly the seizure ends. So that's good. I mean, the Lennox-Gastaut person would have a caretaker for that. So they absolutely, I mean, would, as far as any of this part of it, the likelihood is a lot of these people have one of these 3 conditions here, these inclusion criteria. So yeah, there are people with Lennox-Gastaut, and if they meet these criteria, we'd be happy to have them in the study. They certainly would be eligible.
And we will be sending a follow-up email, so we'll include a link to the recording from this webinar. So if you want to rewatch it and absorb a little bit more of the information that you may have missed in the first go-around, you'll be able to do that. And we'll have contact information in that email as well, in case anyone thinks of questions after the webinar is over.
And we beat the shut off of the power.
We did.
Yeah.
All right, thank you, everybody. Have a good day. Thanks very much.
Thank you, Dr.
so much,
Valeriano.
Dr. Valeriano. We appreciate your time.
Okay, bye-bye.
Bye-bye.